It's time for Solutions for Seniors to Be, here on WATD. Here to help make your golden years golden, offering guidance on programs and services available to you and your loved ones in your retirement. Now, here's your host, Chris Shea.
Good Sunday morning. Hopefully it's the right place and the right time for you here. Even though I do, like I say every week, love Dr. John. Brings me back to my days in New Orleans when I was a younger person. And, well, my parents loved visiting me there. Unfortunately, they are no longer with us. But hopefully some of the things that they had challenges with in their lives, we can help you get through some of those things in a different way. It is Sunday morning. Again, welcome, Chris Shea, with BPS Financial Services. I have a guest today. Her name is Renee. She is from the Norwell VNA. And I'm going to let her introduce herself, and then we'll chat about all the wonderful, fun things that they can do to help you and your loved ones as they, well, enter their senior years. Good morning, Renee.
Good morning. Thanks for having me.
Thanks for being here.
Yeah. So, I'm Renee McInnes, and I'm the CEO of NVNA and Hospice, and we also have the Pat Roach Hospice Home in Hingham.
Lots of stuff.
Yeah, lots of stuff, and love that you said fun. So we'll try to talk about some of the fun things we can do.
Hey, well, things, life. We had a guest on a couple weeks ago, and Cheryl Botiari. Do you know Cheryl? She talks about death and the end of life experience and how you want to shape it to the way that you want to, and how empowering that can be, and the conversations you can have around with that. So I don't view the end of life as potentially a miserable thing.
That's right.
It can be, but it can also be a celebration.
100%. Yes. It's a blessing if you're with your loved ones at the end of life and you get to experience that and be there for them. I recently had that experience with my mom, who was 92, Alzheimer's, and suffered way too long with that disease. But we were all there for her end of life and for those days, and it was just a blessing, really, truly. So, yes, you're right. Yeah. It can be good.
Yeah. I mean, my mom passed away in the pandemic.
Yep.
So she was at a facility up in Norwell, right off the highway, and the only person that could go in was me.
Yeah.
So I arranged literally with people when my mom was in hospice at the end, to, as I pick up my phone, like you can see it on the radio, I arranged for Zoom calls and for FaceTime with people that couldn't come into the facility. And
that was rough.
It was challenging.
Very challenging.
Some people didn't want to actually talk because the end of life, she didn't look the way that people wanted to remember. And I was like, look, we can take off the video, just talk and share your day. And she can hear, but she's not going to communicate back. It is what it is.
Right. All part of the journey.
But it was a gift for me, too, once we had chosen to go to the hospice path and stop the rehabilitation path. Right. I stopped fighting with her. Yeah. Because
that was what her goals of care were.
Yeah.
Right.
And she, stopped participating, all that stuff. And I was trying to keep her going. And she was like, yeah, to heck with you. I'm done. I'm done. Yeah. And the last 2 weeks were wonderful because I didn't fight with her about anything. I just gave up. She hadn't eaten in like a month or whatever. And I told her I was going to Taco Bell one day with my daughter in the car. And my mom goes, oh, I'd love some Taco Bell. Right? I'm like, okay, great. I'll bring you Taco Bell tomorrow. Yeah. So I showed up with 2 bags of Taco Bell. Probably cost me $20 to get this Taco Bell order in. Right. And I showed up at the facility, and all the caretakers are going, she hasn't eaten. I said, yeah, but she asked for Taco Bell, so she's getting it.
That's what she's getting.
And if she doesn't eat it, guess who can eat it? You can. So, accept a free food from Taco Bell.
Right.
And then they were like,
God bless her.
Yeah. And then they're like, oh, really? We'll take the free food. Anyhow, so your mom, Alzheimer's, was it a prolonged experience or?
Oh, yeah. So sure. About 13 years, really, from, symptoms
that's a long
to,
one.
yes. But great care with, obviously, my VNA and Hospice's palliative team. When she was first diagnosed, to the hospice team at the, end of life, and the chaplains and the social workers, the nurses, amazing care, and just such a great team, and so wonderful for the family. As you know, hospice is just as much for the family as it is for the patient.
It's more for the family.
Yeah. At the end, it's more for the family.
It is.
But also keeping her comfortable was, the most important thing. And they did an amazing job. And so, like I said, it's a blessing to be there and be able to meet your loved one's goals of care, that you know what they would want, because, as you know, planning is so important. So financial planning, as you do, but also planning with your family about those difficult conversations, and having those conversations when you're able to, and you're cognitively able to make decisions, to talk about, like, what is it? What is your end of life look like for you? And what do you want? And making those wishes known. And my mom and I did that with her primary care physician. So I felt really lucky that I knew what she wanted.
Oh, fortunate. Totally.
Because not everybody knows that. And as you said, your mom made it clear to you, this is what I want. And you went, thank God, you went with that, because that's, her journey.
Yeah.
And she knew. So I think it's important for people to have those conversations early on. And we work really closely with primary care physicians and our referral sources to try to get those goals of care conversations done earlier, so that we can get people to the right care setting.
Yeah.
So
you talked about Alzheimer's, and I think we talked about this off air, but I do presentations for the Alzheimer's Association on managing money. And one of the craziest stats, the 44% of caregivers, this is not the people with Alzheimer's, but the caregivers suffer from depression.
Oh, 100%. Yeah, and they sometimes get sick before and pass before the person with the disease does,
Well, the depression comes, and there's anxiety in that as well.
Mm-hmm.
That comes mostly from the people that don't know if they're doing the right thing.
Right.
Because they haven't had that conversation that you talk about having with their significant other, parent, whatever the case may be, about how they want their care to happen. And because people think, oh, I'm going to be burdening people with how they want to care for me. It's like, no, you're unburdening them from the lack of knowledge of what you actually want to have happen. Having a playbook by which to care for someone, all anxiety goes away.
100%. We run some Alzheimer's support groups, but we also have a certified dementia practitioner, and she is so busy consulting with families about, the planning, right, for the future. And it's definitely, get your legal affairs in order, your financial affairs in order, but also your goals of care and your wishes known, so that this can go the best possible way. It's difficult, and the caregivers do suffer from depression, anxiety, but oftentimes that stress causes them to be sick, so that we try really hard to work with them to say, look, you're going to get sick. If you continue this, you need help. Let's figure out how we can get you help, the right help that they can afford financially, because that's the other piece. I mean, it's tough, but it's one of the diseases that can really cripple families financially,
Yep. And I have a friend, she's a therapist, and she describes people as cookie jars. And yes, it's Sunday morning, so hopefully having a good brunch and not having too many cookies. But if you think of yourself as a cookie jar, when you help other people, people are taking cookies out of the cookie jar.
Mm-hmm.
And if you keep giving and giving and giving,
right,
eventually the cookie jar is empty.
That's right.
And now you've got nothing left to give, and you can't take care of anyone. So she would always say, fill your cookie jar.
Yeah.
Fill your own cookie jar.
That's right.
Because nobody else is going to fill your cookie jar for you.
100%. Yep.
And you absolutely cannot take care of someone as much as you want to if you can't take care of yourself.
Mm-hmm. That's exactly right. Everybody needs to sleep. Everybody needs to eat. I mean, so there's
not too much in the holiday season.
Yeah,
but,
exactly.
Don't go up to the buffet table 3 or 4 times at the holiday party. Stop it twice.
Don't go completely off the rails. It's hard to get back.
Yeah, I know. I put on a few pounds since the end of the summertime, but I'm actually planning on rechanging my diet.
Well, good.
So, again, taking care of myself.
Yeah, that's awesome.
You got to do it.
Food is medicine. I'm a big believer in that. Yes, 100%.
Cookies are wonderful, but they are not good for the
time and place.
The body. Wonderful for the soul. So we're going to take a quick break here and hear from the sponsor, me, and we'll be right back. Are you fit to retire? I'm Chris Shea, financial advisor with BPS Financial Services in Marshfield. I work with clients to create a 100-day plan that can help get you started so that you can get the most out of your retirement. You've worked your whole life towards your goal of retirement. Let BPS Financial Services put together a plan that will help you enjoy your retirement. Find out how a 100-day plan tailored to you can help you get started in your retirement at fit2retire.com/Chris-Shea or call 781-733-5996. That's 781-733-5996. And now for my fast red disclosure, as this has been compliance approved.
Chris Shea is a registered representative offering securities and advisory services offered through Cetera Advisor Networks, LLC, member FINRA/SIPC, a broker-dealer and registered investment advisor. Cetera is under separate ownership from any other named entity, located at 752 Ocean Street, Marshfield, Massachusetts, 02050.
That's 781-733-5996. And welcome back. Now that we've
Thank you.
talked a little bit about cookies, let's actually dive in a little bit more about what the Norwell VNA does, because the services that you provide are critical.
Mm-hmm.
And I've had a couple guests on here that talk about hospice versus palliative care, and most people hear those words and freak out because they have no idea what they actually mean.
Right.
So can you, in the good spirit of Dr. John, educate everyone on what they mean and kind of what you guys do? Right?
Absolutely, yeah. All right, well, let me just start with what we do and who we are. So we've been a home health organization for 103 years now, right?
So you're new at this.
Very new. I look pretty good, don't I, for 103?
You don't look a day over 107.
So, and back then, they had public health nurses and doctors who did visits to the home, right? And then fast forward to when Medicare, our federal government, CMS, came into place to stop paying for those services, and Medicaid, and then hospice really wasn't reimbursed until it's only been about 45 years now. So that was brand new. That was more of a public health, or a lot of times spiritual groups that were providing hospice care at home.
The church originally.
The church, yep. Kind of was really started in England, was ahead of us there. But anyway, so we do home health services. We have about 700 patients on census, average daily census a day. And home health is basically for any care you need at home, IV therapy, you've had a hip or a knee replacement, you need physical therapy, you need wound care, the whole spectrum of things, just maybe a safety eval for a frail elder person at home to make their environment more safe. So those are our home health services. And then we provide palliative and hospice, and I'll explain more about that. And then we have the Pat Roach Hospice Home in Hingham, which is a 12-bed residential hospice home for patients who, for many different reasons, aren't able to pass at home, maybe don't have the support, or they are exhausted. The caregivers become exhausted caring.
We talked about that,
Yep. And so it's a place where you can just go and be the family. And I can talk a little bit more about how that works. But let me delve into a little bit about the palliative.
12 beds is intimate.
12 beds. Yep. It's
small.
But it's a big, was a, back in 1930, the summer home of the dean of Harvard Law School came for 4 weeks with his family, right? So it's on Turkey Hill. It's beautiful. Beautiful old structure.
Small palatial establishment.
Exactly.
Yeah.
Beautiful, right next to the Ware Farm. So, I mean, the views are lovely. So it's a very, very beautiful, serene, peaceful place. And
But my point was, it's not a hospital.
No, it's not a hospital.
It's not a 1,000-seat, 1,000-bed facility.
It's like if you were home. It is,
right.
And we hope to always keep it like that, so that it's as if you're home. And for the families, there's many different areas that they can just go relax, unplug, check their emails.
Little garden.
Go to the garden, take a walk. There's walking trails, and so it's really very nice. And the family gets to just be the family, right? Because there's 24/7 clinical care for them, for their loved ones. And it's,
you just get to show up and be with them and love with them.
Yes, exactly. Right. And we care for them as much as the patient. And you need a cup of coffee, a cup of tea, or a muffin, we're there, right? So we just try to do the best we can to meet them where they're at. And it's amazing. It really is, for people that need that. And the room and board is not covered by any insurance, because their insurance thinks, well, you could be home, right?
Yeah.
This is like your home. So it's $500 a day, but we do raise money for people that can't afford the care. So no one's turned away for financial reasons, which is another amazing thing that we can do.
That's phenomenal.
Yeah. So it's great. It's great. So we're very blessed to have that, and we're very blessed to have philanthropy in our world to support the gaps that we have. Yeah.
And it provides people, I would guess, a sense of dignity at the end.
100%.
And that's what people are most looking
100%.
for. I talk about my parents, my grandparents, and my grandmother was a nurse, and she was in the hospital. She had dementia at the end of her life. And half the time I'd show up and she'd swear at me, and half the time she'd love me, because she just wouldn't recognize me. And it was
right.
I was like, okay, great. This is the day it's going to be. We'll live with it and we'll deal with it. But in one of her moments of clarity, and I was down in New Orleans at the time, but I was visiting, and we were talking, and she mentioned that she missed her husband, who had died 8 years before.
Yeah.
And I said, Graham, it's okay to go. And she said, what? And I said, we're going to be fine.
Yep.
It's going to be okay. And like within a month, she had passed.
Yeah.
She was looking for permission and knowledge that we were going to be okay, because she was the matriarch.
That's right.
It was me, my brother. We're the only two grandkids. Me and my mom and my aunt were the only two girls.
Yeah.
2 children. She wanted to make sure we were going to be okay. And
right.
she just needed that approval.
Right.
And once she got it, she's like, okay, I can
right.
leave knowing that things are going to be all right in spite of me not being here.
Right. That's right. And I think for us, with our hospice program, we have about 200 patients on our census for hospice on any given day. And we are the biggest referral source to the hospice house, because the nurses or the social workers and chaplains might identify a family and say to the family and the patient, they're exhausted, right? Or that care, we need to give people permission to admit that maybe they don't want to do that care. It's very intimate, as you said, and
harsh.
And it's can be difficult, and medication administration can be very scary for people. So people need permission to know it doesn't mean you don't love your loved one and you want to help them, you want to care for them, but being there, holding their hand and caring for them
are separate things.
Is separate things.
Right.
And the physical care can be done by the clinical staff. So I think sometimes people feel like they get the guilt of, I really should keep them home. Well, then get some extra help, because it's not easy for everybody.
I do consulting work for small businesses on how to grow and how to develop. And one of the things I tell them is, know what you do the best and get other people to do the rest.
That's right.
And unless you're in the area of home health care,
right,
all the stuff is, I didn't know how to do any of it, and I was completely fortunate, maybe is not the right word, but my mom went right from the hospital where we got her admitted to the ER. Then she went to the rehab center and stayed in the same facility and just went into hospice care because it was COVID.
Right.
And they were like, look, to take her out of the hospital, take her out of the care and bring her home right now because of the medication she's on would be cruel because she had slipped to the point where she just, in order to be comfortable, she needed medication.
Right. That's right.
Because she had, the path she had chosen. And I am so grateful that I didn't have to bring her home in the midst of a construction zone because her home was being renovated because we were trying to set it up so that if she was coming home and we'd have a room downstairs with a full bathroom, like we were doing renovations in a rush to try and get the house ready. I just told them to just stop, and because if she'd come home in that disaster,
that would have been stressful for everybody.
It would have been miserable.
Right.
I mean, it was bad enough, again, it was the pandemic, so people really couldn't visit. We had to do one at a time if people could make it. I had to make a name list and stuff like that. But it was better than the alternative of me trying to be the one to care for her while doing all this other stuff.
Right.
Because it's not my day job.
Yeah.
And I am perfectly fine admitting that I am not the person to do that work.
That's right. But that's good that you recognize that. And I think people do recognize it oftentimes, but they feel bad that they should be wanting to do that. And I always say, give people permission. There's help out there, and, understand what role you're playing, So, yeah, it's true.
I can remember when my dad helping him out, he's like, "You're going to help me in the bathroom?" He's like, "Don't look."
Right.
I'm like, okay, I'm not looking.
Yeah. No, parents don't want their children to care for them in that way.
Yeah.
No. And
so,
like you said, dying with dignity is so important.
Yeah.
And something we want to give to everybody. But it's so true. Just to answer your question about palliative care, so that could be like a 3-hour conversation, but I'm going to briefly capture the highlights for you because it is a confusing name and definition for people. But essentially the way we look at it is, we have a lot of people that we care for that have chronic diseases, right? So chronic diseases that affect their quality of life, that bring them to the hospital in and out, and they're tired, and they say, I don't want to go back to the hospital.
Cancer.
It could be cancer. It could be congestive heart failure.
Yeah.
It could be chronic obstructive pulmonary disease.
There's a long laundry
There's
list.
a long laundry list. And it could be this chronic illness is just affecting their quality of life. And so we have nurse practitioners and nurses and therapists that work with the physician, obviously, is at the hub of the wheel, but we work with them to meet the person's goals of care. So it's like, okay, what's important to you, Chris, right? So I don't want to go back to the hospital. I don't want to spend another day in the ICU. I don't want to go into the ER. Okay.
This isn't living. This is sustaining existence.
Exactly. Right. And so
miserable.
It's miserable. And so, okay, let's figure out with your physicians what we can do to be able to keep you home. Medication, some lifestyle changes sometimes, as you talked about, maybe diet and other things.
Yeah.
But building up your endurance. So there's several things that we can do, and that's called palliative care. I know it's to palliate, but it's palliative care. Now, it doesn't mean you're hospice eligible or that you're going to be hospice eligible. You could be on palliative care with oversight from the nurse practitioner for several years, right?
Yeah.
But it just means you're getting that support. Or sometimes you are more hospice appropriate. And so then we have those conversations with families and patients and physicians to say, it's such a rich benefit, the hospice benefit. It's just giving you extra support to keep you home where you want to be for a longer period of time and be able to meet your goals. What are they? They're different for everybody. And so that's really simplifying it, but that's what we do.
We do only have a half an hour on the radio. So the simplification has to occur at a multitude of levels.
Right, right.
But no, it's I know a lot of people, when I say palliative care, they give me like this cross-eyed look of what the heck are you talking about? I'm like, essentially it's at the end of life where you get to plan out how you actually want to live. And they go, what do you mean? I'm like, well, sometimes a lot of people have a challenge because they think that because the doctor makes a recommendation, they have to do it.
Right.
But it's the patient's life, and they have the choice as to whether or not they want to follow through with the recommendation from the hospital. And Western medicine, as we well know, is mainly based upon diagnosing and drugging. You know, I have gout. I've had gout since 2007, 2006 maybe. I'm not on any medication because I changed my diet.
Right.
Because I didn't want to be on medicine for the rest of my life when I was in my 40s.
Right.
And I was like, I can't see a life of 30, 40 years of taking this pill every single day.
That's right.
I made a lifestyle choice.
Yeah. And that's oftentimes the most important thing are those lifestyle choices that we make. Changing diet, exercise. Yeah.
Well, for me, essentially, I can't drink beer.
Yeah.
Which, people,
it won't kill you.
Yes. Do I miss drinking beer on occasion? Absolutely. But I can drink anything else under the sun.
Oh, there you go.
So, people are like, you want to get a beer? I'm like, you get a beer, I'll get a drink. And they go, what? I'm like, I can't drink a beer. But yeah, so when I talk to people about making a lifestyle change, I've done it. I've actually gone and I used to drink a lot of beer. I enjoyed it, but I didn't enjoy the pain of gout. And I was like, okay, you know what?
Right.
Let's make the lifestyle choice.
That's right.
Let's do what we really want to do, which is not be in pain.
Exactly. Right. That's exactly right. Yeah, I'm with you. Totally agree. And I do agree that, with more education, consumer awareness, just really highlighting the options for people and educating people because people don't understand. And today, right, post-COVID, we knew the nursing crisis was coming for staffing, but it just accelerated. All those baby boomers retired earlier because of COVID. And staffing challenges, and the hospitals are just, you can be in the ER for days now, try to find a primary care physician. There's definitely a crisis in healthcare right now.
Yeah.
And it's so more than ever, care for yourself. Take care of yourself.
Yeah. The hospital is no place for sick people.
Right. You want to be there if you need to have surgery or be in the ICU. Right. Yes, exactly, of course. And they do a great job, but they're just stretched to the brim. They don't have enough staff, and there's just not enough. The capacity isn't there, and it's everywhere.
Not changing soon. It's not changing anytime soon.
It's not changing today. Let's put it that way. Yeah.
Yeah. So this has been great. Unfortunately, we are coming close to the end of our time. If people were interested in learning more about the Norwell VNA, how would they go about interacting with your team? Maybe not necessarily you on a daily basis. But how would they get in touch with the Norwell VNA?
So our website, nvna.org, and
say that a little bit slower because
N as in Nancy, V as in Victor, N as in Nancy, A as in Apple .org, and follow us on Facebook, Instagram. And you can follow me on LinkedIn, and also our direct number to the organization, 781-659-2342, and follow the prompts. And if you'd like to speak to me, you can certainly ask, and they'll put you through to my voicemail. So thank you.
And then she'll get back to you.
I will get back to you. I absolutely will.
Yeah. No, she's this has been good. If you did have any one recommendation for somebody who's approaching this time in life or have a loved one, what would you give as a recommendation?
Oh my God, communication. Just talk to each other and plan. You need to do some planning. So I think it's important to plan, have a will. There's a lot of people that we see that don't. Financially plan. Really educate yourself on what health insurance you're signing up for. What does that mean in terms of access to care? So really, I think education and communication with your family and your loved ones about what your wishes are and your goals of care for the future. And it's never too soon to start having those conversations. You don't wait till you're terminally ill. So you start them when you're well and you can think clearly. So that is my recommendation, because the first thing we do when we see somebody in crisis is we say, okay, do you have a will? What's going on with your financial affairs? Because it all plays together. So
yep, it all does.
Yeah.
Well, thank you very much. And this is the end of today. Hope everyone has a wonderful Sunday, and we're on to the car guy.
I've been in the right place, but it must have been the wrong time. I done said the right thing, but it must have